Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
My name is Dr. Jay Granzow. I'll be talking about lymphedema and lipedema, or versus lipedema, differences in diagnosis and treatment. These are the sponsors of the LE&RN Symposium series, and we thank them for their support. This information is not a consult, but it's certainly my take on lymphedema surgery and lipedema surgery. But please see your own physician for specific advice in your situation. And I personally have no sponsors and no disclosures, and I'm not being sponsored by any of the sponsors who are making the LE&RN series possible. So again, I work with my center, the Granzow Lymphedema and Lipedema Center. We've moved to Jacksonville several years ago, and we are based out of Florida now. Been doing this for quite a long time, and certainly we have very high expectations that we set for ourselves and our patients to be able to provide good outcomes for everyone. I'd like to share some of that. No talk or no presentation is ever complete without special thanks to all the people that make this possible. This is not about me and some surgery. It's about the team effort and all those people that spend a large amount of time working with our patients, making sure that they're well taken care of, and making what I do work. I couldn't do it without all these very, very special and important people in our office who work with us, both on the clinical team behind the scenes to make everything possible. I'd also like to thank this team here at home. So again, certainly there's always a lot going on in everybody's house, and I really appreciate them being able to give me the support that I have so that I can take care of the nice patients that we have. All right, lymphedema and lipedema. I'll start here with my journey. Really began with the journey for lymphedema, and started with Dr. Koshima in Tokyo in 2005, and really we started doing LVAs. He was very generous to have me over there in the OR. So got a few more wrinkles and a little bit more experience in that since that time, but very much a big shout out and thank you to Dr. Koshima as to where we started initially. Also Dr. Stutz, Dr. Rapprich, they were two physicians that I went to learn more about lipedema. We had already been taking care of lipedema patients for quite a while. And Stutz has really, he's in a small Bavarian town in Germany, and he really has pioneered a lot of the lipedema treatment that we have. And other surgeons like Dr. Rapprich, he's over in Frankfurt area, have really always really furthered our knowledge and understanding of how to treat that very difficult condition. Currently, we have moved from California to Jacksonville. This was several years ago. We were able to have our own center, our own training center, where we have lymphedema therapists also being educated as a training center as well, because it's such an important, the therapy is such an important aspect of what we do, the results that we can achieve. Okay, so lymphedema and lipedema, pardon one moment, let me turn this off, are both, they sound very similar. They're both very debilitating, but they're very different conditions. The personal and emotional components are very real. The impacts of these conditions on patients are quite significant and often very underappreciated by, I think, the public at large. And what also happens is that lymphedema can occur in lipedema patients quite frequently, and I'll go over how we can separate those out. Treatment must be part of an organized system in both cases. I think that's very critical. I think, again, it's part of a team that we take care of our patients, part of a system that we take care of patients. We cannot just see someone on a video, in my opinion, and perform some surgery and hope that that's going to magically take care of them. There's a process that we go through to get that patient that best result that we can. So lymphedema and lipedema, these are two very typical presentations of both lymphedema and lipedema. They're different. Lymphedema typically is asymmetric. Lipedema is symmetric. There's a body habitus shape that goes with lipedema that's very common, such as this lady has here from the waist down, and we'll go over those further. So they can be similar and appear similar to the untrained observer, and photos alone will not be able to differentiate them in many cases. So the two pictures I gave were very standard appearances for lymphedema and lipedema, but that's not always the case. So a thorough history and physical exam are very important. We also follow up those in almost all of our patients with imaging studies such as lymphoscintigraphy, which is a nuclear medicine study done in the hospital on a very complex machine, or ICG, which is indocyanine green mapping, which we do straight here in the hospital. We do agree that a type of imaging and a confirmation of the diagnosis with an objective imaging modality is required for surgery recommendation. The other part is that that differentiates these is that lipedema has a much greater and more significant emotional component for patients. Patients do get much more emotional. There are many theories as to why this is, but it's that is a significant difference between both. And sometimes they may look similar. So which patient is lymphedema? Which patient is lipedema in this case? Well, that's lymphedema and that's lipedema. This happens to be a patient with bilateral lymphedema, and lipedema is almost always bilateral. So they can look similar even in photographs. So what are the differences? Well, lymphedema versus lipedema. Lymphedema is a disorder of the lymphatic system. Lymphatic system is your body's natural drainage system that allows the fluid that naturally circulates and cleans the body, especially the arms and legs, to be extracted and removed in an orderly way. Lymphedema is almost always unilateral, meaning that one side is affected or one side is affected much more severely than the other, or it comes on at a different time. Tends not to produce pain, it tends to produce pressure, and infections are extremely common and can be very debilitating. Lipedema is very different. It's a pathologic disorder of the fat cells themselves. The signaling mechanism is different, and there's significant inflammation, which is swelling, fluid accumulation, pain that goes along with these cells. So these fat cells don't play well in the sandbox with the other fat cells. They are, they sensitize the nerves in those areas. They cause swelling, and pain is very common in lipedema as opposed to lymphedema. Lipedema is symmetric. So on the patient on the right there, has roughly symmetric looking legs, and it's a disease found almost entirely in women and driven by hormonal changes. So especially when women get their first period, when there's pregnancy that occurs, or when menopause occurs, are times that the lipedema can get much worse. The emotional aspect is also very significant in lipedema. Okay, so this is another patient with lipedema can be overlapping with lymphedema. This is a patient who was an early stage lipedema who did have lymphedema underlying as well. So the imaging studies for us are quite important, and we feel critical to achieving the best diagnosis to be able to treat that patient in the best way. One imaging technique we have here is lymphoscintigraphy. These are nuclear medicine images. This is at the 3-hour on the right, we can see that so the feet are at the bottom, arms are at the top, the spots are the armpits, and we can see some nice lymph node chains that are relatively unaffected on both sides about midway up the screen. Whereas here in a lymphedema patient, there's a lot of obstruction, meaning a lot of dark area down in the lower legs. You don't have to worry about being able to read these. These are quite significant, obvious to us here as clinicians. And they're a very good way to differentiate both lymphedema and lipedema. Again, we believe that the role of the CLT, or the Certified Lymphedema Therapist, is critical. My clinical team are all trained as CLTs, and we have 2 dedicated CLTs. My PAs are trained as CLTs. My OR nurse is trained as a trained CLT. We really take that very seriously, and we know it's a critical component in treating not only lymphedema, but also lipedema. We perform bandaging right in the OR. So this patient is still asleep under anesthesia, and this patient had a lymphedema surgery, or a SAPL procedure, on the left side. And to keep that swelling from occurring, we bandage that patient directly in the OR and keep that swelling down. That allows us to get ahead of it. We don't need to perform skin resection, and we can provide consistent results for our patients doing that. The bandaging that occurs is using short stretch and very specialized lymphedema foam and bandages. Those are not ACE-wrap bandages. And custom compression garments that are flat knit, custom measured for the patients as well. This is a very specialized and specific way of bandaging and treating that patient that requires quite a lot of training and experience. So lymphedema surgery, I'll go over lymphedema first, and then I'll follow up with lipedema as to how they're different. For us with lymphedema surgery, we have high expectations that we set for ourselves. We've been doing this a long time, almost 20 years. And our expectation is that for patients that come in, we will achieve a volume reduction or treatment of the affected arm and leg such that it will approximate the size of the other unaffected side. Meaning that if someone comes in with leg lymphedema, I will expect after they have been treated by our center that they can shop, for example, in the normal clothing section. These are expectations. We expect to significantly reduce the infections, improve the quality of life, and eventually reduce the need for the compression garments that keep the patient stabilized. We do achieve significant improvement in 99% of our patients in 1 year, within 1 year after surgery. Our consultation process is quite involved. We have extensive telehealth and screening processes first. Essentially, all of our patients come from out of town. So we want to make sure that that patient will be able to benefit from us before they make the long trip to see us here in Florida. Patients that we feel we can help, then we set up for an appointment, and the full evaluation takes about a day and a half. So we have lymphoscintigraphy, ICG screening, full CLT therapy, PA and surgeon evaluations, and also the introduction and discussion of the insurance process. So I'm no good at that. We have a whole back office team that does that to make sure that the patient is cared for from all the different sides. Overall, less than 10% of the initial patient inquiries result in a recommendation for surgery. So we're quite strict on our screening process. One of the things we do in the office is perform the ICG imaging. So that's indocyanine green. Those are small injections that are performed at the feet. In this case, arms can be done as well. Here's a patient clearly with lymphedema in the left leg, which is the bottom of the screen, and the patient is unaffected on the right side, which is the top of the screen. So the unaffected side has the nice, discrete, almost web-like network of lymphatics, and we can see the lymphatics directly through the skin. The other side is extravasated. Everything is blown out and pushed out. And this is like, having traffic on the Google traffic map. So there we have clear obstruction, and the leg you can also see is much, much larger than the other side. We have this, in the last year, purchased a high-frequency ultrasound machine. We found that very helpful for use, especially in surgical planning. We can see not only veins, but we often see the lymphatics directly, and we can better plan out the procedures that we will perform and the areas where we will be making our surgical incisions to be more efficient in the operating room, to be able to get more done and to be able to make better connections. Another ultrasound picture here. This is where we actually see a valve in the saphenous vein. So we can see up at the center of the image there, the vein, and here we're turning it sideways, and we can even see the valves themselves, and you can see the valve opening and closing. We like valves because all the side branches that are below that valve then don't spill blood back into our connection to make the connection stay open better and not clot off. Okay, so lymphedema imaging and disease progression. This is a typical lymphedema patient with a stage 2 problem. The left leg is affected. Again, lymphedema is an asymmetric condition. One side will be worse than the other. Here, MRI scan, this is a different patient, but can be performed if needed. And you can really see that there's a lot of fat and soft tissue underneath the skin between the muscle, which is the center portion in the bone, and the skin surface itself. We find that MRI scan is usually not necessary with our treatment process at this point, but sometimes we can order it. This is the same patient from the previous scan. The right leg, which is on the left side of the screen, is not affected. And this is the normal tissue that's above the muscle up to the skin. The gray in the middle is the muscle and bone and all the vessels and supporting structures that are present. And this is what a normal leg looks like on a cross section or a slice. This is the same patient, same level of the thigh on the opposite side. And you can see that this tissue underneath the skin is much thicker and more affected. There are white areas which show the fluid that's present. Even though the patient doesn't have pitting, doesn't feel like there's any fluid there, on imaging, we can find that there's still significant fluid present in this patient. So this patient is much bigger, and we can, again, confirm that on MRI scan. This is a slide borrowed from Dr. Borson, and this is a previous cadaveric or cadaver specimen from a patient. Obviously, the one side with lymphedema has the significant solids which are present underneath. So lymphedema starts as a fluid problem, meaning there's backup of lymphatic fluid. That inflammatory fluid causes damage to surrounding tissues. If the fluid's caught early, it's called a stage 1 lymphedema problem, where there's just fluid swelling. However, if given time, the fluid will then cause permanent deposits of fat and other proteins. That can be seen on the MRI scan as it was previously, or in this slide here where we actually have a cross-section of that permanent solid deposit. This is a stage 2 lymphedema. In stage 2, we know we cannot perform microsurgery to drain the fluid because the fluid drainage is insufficient. The solid here needs to be aspirated out or suctioned out to be able to bring that armor leg back to a normal size. Microsurgery in this advanced state will not work. You will be taking away from areas that will otherwise also get inflammation and fail to function, and be fewer sites that you can use in the future. Here's an example of a patient that came to our office. She was previously treated. This is how she looked when she came to the office. Lymphedema clearly on the right side. She had had 2 previous lymphedema surgeries that didn't work before because they were microsurgery procedures. There was a lymph node transfer or a VLNT performed, and there were LVAs, which are lymphatic venous anastomoses, in an attempt to drain fluid. However, she has solid that's present, so the patient will feel better. The swelling might improve a little bit, but there's no reduction in volume because that volume is all solid. That solid needs to be aspirated out or suctioned out. The fluid, small fluid drains cannot make that happen. These are the previous surgical scars from the surgical sites, again, performed elsewhere. We performed a Granzow SAPL surgery, so suction-assisted protein lipectomy surgery for the right leg. Actually aspirated out that solid. We got 5,700 cc's of solid. So put it in perspective, 2,000 cc's is 2,000 milliliters or 2 liters. So 2,000 cc's is 2 liters. Same as a 2-liter soda bottle from a from a convenience store. She has almost 3 of those 2-liter soda bottles in excess volume present in the leg. And with that procedure, we were able to get her down at 1 year for a result such as this, which is a consistent result that we expect. Our process is that we treat the entire arm, upper and lower leg, in 1 surgery, have 1 recovery. We feel that we can get better measurements on our compression garments that are proportional afterwards. After they're measured, we bandage the patient in the operating room, keep that volume down. We take those measurements and we put on a flat knit custom compression garment that's proportional on that side, and that keeps that patient from swelling further. In fact, the swelling will continue to improve or we downsize those garments over the next year to normalize that arm or leg. This is how it might look after we're partway through. So we have a tourniquet in place. That means that I go and borrow this from orthopedics. So what it does is it's placed on this thigh there. It keeps bleeding from happening below that. If there's a knee replacement performed, if there's a bone surgery being performed, if there's an ankle surgery, they all have this tourniquet so that there's no bleeding coming out of that area. That keeps our swelling down too. And you can see that there's a tremendous amount of aspiration that's already done. I follow the direction of the lymphatics so we don't further damage them. The direction of the cannula is this way. And this is how big the leg was before surgery. And you can see on this side how we've gotten that leg down in volume already on the outside, and we'll perform the same on the inside to really get rid of that excess volume, which can't be removed consistently in any other way. This is how a patient like that might look after the bandaging, where we have the flat knit bandages placed. This is a patient with an actual compression garment in place, instead where we have additional bandages around to capture some fluid too. So there's a lot that goes into each of these surgeries that's outside the actual surgical procedure to keep that swelling down and to get that patient well on their way to healing. Again, I don't routinely perform skin excision. This is a patient with bilateral lymphedema, so that's less common. So we performed 2 separate SAPL surgeries on different days. We can't do them together. There's too much recovery. But both of those get us down with the consistent results. So that patient is getting into the normal clothing section. The recovery is much better. The movement is much better. This patient, I mean, just the amount of weight on each leg and on the musculoskeletal system, the amount of inflammation that's decreased, the improvement in the drainage really makes those patients feel better and more clear thinking as well. It's quite incredible. The skin in lymphedema does contract on its own. So you'd wonder, where's all that floppy skin going? Well, one of the few advantages of having lymphedema is that the skin is so inflamed that it actually shrink wraps down, and it will shrink wrap down around those legs in almost all cases. In this case, there was no skin resection required on either side for this patient here. This is very different from cosmetic liposuction. If we suction out a patient, for example, cosmetically, who had legs that big, they would have floppy skin. They don't have the inflammation in the skin to contract it, and they would have subsequent folds that we do not. Cosmetic liposuction has a very different indication, means it's used for different things. It's for pre-appearance. The workup is different. The procedure is much less intense. The cannulas I use are different. The settings I use are different. We perform the SAPL procedures in the hospital. It's a 4 or 5 hour operation. We have therapists coming in afterwards. We have very intense post-operative care. The whole setup and process are quite different between the 2 procedures. The lymphedema therapy is absolutely essential. And this is because lymphedema patients can't clear that post-operative swelling. So whenever you have an injury or a surgical procedure, there is swelling that occurs as a result of that surgery. A patient without lymphedema can typically clear that swelling over time. A lymphedema patient cannot. If we don't address it in a very specific way, that swelling will come back and the patient might even get worse after surgery. So the aspirate, meaning the material that we get out of a cosmetic surgery patient, might look thin, custardy, very smooth, is mostly fat with a little bit of fluid on the bottom. So this is what a cosmetic surgery aspirate might typically look like. Lymphedema is more like getting curdled milk out of patients. There are different layers there, and there are patients with different severity of lymphedema will have different amounts of distortion in their tissues and in the fat cells themselves, so that they are quite different with what we get out. My cannulas and even my machine has to be different for many of the patients to be able to even treat them. Otherwise, again, I have a larger than average cannula. It's very specialized. Otherwise, I'd be trying to suck a milkshake through a coffee straw. It wouldn't come out. And the volumes that we get out are different. This is from one leg. So we can get out thousands of cc's from a single leg. We can do it very safely, very reproducibly. We perform the procedure again in the hospital. We use a tourniquet. We use very specialized processes and methods to make this safe for the patients. And we can be able to treat that entire leg and get that patient well taken care of in one surgery for that one side. Here's an example of a lymphedema surgery patient. So she has a very severe condition. She is affected on both sides. She previously had resection surgery performed elsewhere where she has significant scarring in her lower leg. You can see right here where sections were cut out, but again, she was very insufficiently, incompletely treated. This is a difficult to treat patient, obviously. This is how she looked before surgery. And again, you can see the scars, especially on that right side where attempts were made at previous treatment. She has issues with healing the sores in her leg, like on the bottom of the left side. So Granzow SAPL surgery in that left leg was performed, means we aspirated out all the solids underneath the skin. And this is how she looked on the OR table after that was complete. Again, the skin is already on its way to shrinking down even in surgery, and that will come down further. We took out 6,900 cc's of volume. Again, 6,000 is 3 2-liter soda bottles, so 3.5 of those. And this is how she looked before, and here's how she looked 4 months after her first surgery on her left side. Again, very reproducible result. It's an expectation we do have for our patients. So then she came back, we did the other side, and this is how she looked in surgery immediately after surgery. Again, we took out another 5,000 cc's on the less affected side of all this excess volume. And so when she started here, this is where she ended up 2 years and 9 months later. Now, when the patients are reduced, I'm essentially taking what's a stage 2 problem and turning it into a stage 1 lymphedema problem, meaning I've addressed the solids, and the swelling here is entirely due to fluid. She wears compression consistently to keep that fluid from, again, starting that lymphedema process and making it progress back to a stage 2. Here, this is a permanent result. This will not reaccumulate as long as she takes good care of herself with the proper compression. Now, the cannulas that I use, the methods that I use, are designed specifically to avoid damage to the lymphatic system. This is how ICG might look in a very advanced patient. So this has very poor flow already. And this is how that same patient might look afterwards. So it's essentially unchanged from before. So the SAPL surgery does not damage the already damaged lymphatic system, or it doesn't further damage that already damaged lymphatic system. After we get them down from that stage 2 problem back to a stage 1 issue, that's when I can go back and perform microsurgery, so lymph node transfer, or in this case, LVA surgery, to repair those drains, to repair that, to produce new options for that patient to remove that fluid without relying on the compressions as much. So those lymphaticovenous anastomoses are connections from lymphatics to veins to provide additional drains to further treat that patient. And here, this is that exact same patient. I was able to find multiple great solid lymphaticovenous anastomoses This is another way to look at it. This is with the ICG, and we can see the lymphatic is down there. It's sewn, hand sewn under the microscope right there. You can see the sutures, and it flows around there into the vein. There's a valve there so that the blood does not flow back into the lymphatic. I find a vein with the valve, and we can see it spill in a one direction way from the lymphatic to the vein to further help treat her issue. I'll touch on the microsurgery briefly. Again, this is still the lymphedema side because lymphedema, again, is a disorder of the lymphatic system. I do want to repair the lymphatic system. Once we've dredged everything out with the SAPL surgery for an advanced patient, then we will keep that volume down by improving the drainage afterwards. This is a photo I made with Dr. Koshima back in 2005. The microsurgery needles and sutures are extremely fine. So this is a fine human hair. It happens to be my hair in this under the microscope. That's the regular ballpoint pen. This is a standard microsurgery needle, the bigger one, and suture. And this is a lymphedema surgery suture and needle, so much, much smaller. In fact, the needles are so small that some of the staff have trouble seeing them. We can see it under the microscope, or if we're used to seeing these all the time. This is a close-up. The needle's on the right with the suture present. This stick, what looks like a stick here, is actually a 5-0 suture. So it's a normal suture that you would see if someone, say, had the emergency department sew their hand or their face. They would have sutures that are that big or bigger. So that's the actual suture string. And this is where a lymphatic venous anastomosis was performed at the green arrow, and you can see small sutures connecting the lymphatic and the vein by hand. These are much less than a millimeter in size, so this is a 1 centimeter and even 1 millimeter ruler marker, and that's one of those sutures inside that lymphatic just to give it scale. How do we separate them out from the vein? How do we know that something's lymphatic and not a vein? Well, one method is to use the ICG dye in the operating room through the microscope. We can see that the lymphatic vessels will often light up and glow, whereas the veins, which are behind here, don't take up that dye. And we can see the video from both of those there. Here's a connection that I performed. The lymphatic's coming from the top. It's connecting into the vein with the valve at the bigger portion of the vein. So it allows one-way flow from the lymphatic down into the valve. So the lymphatic's from the top, connecting in a hand-sewn way to the vein branch underneath, which then connects into the larger vein. And there's a valve between the vein branch and the vein itself. This is the direction of the lymphatic drainage. The anastomosis, which is the connection, is a hand-sewn connection between the lymphatic and the vein. And there's a one-way valve in the vein present here that keeps the blood from flowing back into that lymphatic system and ruining our connection. So we can see that the connection goes from the top, lymphatic there goes down, and it flows down into the vein. What was neat about this connection here is we could see it this way. There's some blue dye we can put in there too. So the lymph gets dyed blue, and we can really see the lymph flowing from above down and into the vein in a one-way fashion like that. And we can see it flowing down in there. Even better if we use ICG, we can see the lymph, which takes up the ICG, flowing down from the top, and we can see it now right there pushing into the vein and draining and creating that 24 hours a day, 7 days a week, constant leakage of lymphatic back into the drain to decompress that affected arm or leg. And a typical result might be that we get both legs down and we can significantly reduce the amount of compression required after the surgery. Here's a patient who came again to us, had previous microsurgery performed on what was a stage 2 leg with solids present. So we performed the SAPL surgery, plus then a lymph node transfer and LVAs on that leg. And this is a result 5 years afterwards. So the left side is the affected leg. It's now smaller. That's the recipient side for the lymph node transfer. LVA is down. These are photos that she had sent us. So this is how she looked beforehand. And then this is her on Table Mountain, which is off Cape Town in South Africa, having taken the very long flight successfully, no issues from the United States down there, done the whole hike up the mountain with the guide, and having a really good control of her leg, which had normal size. Okay. Now that's lymphedema treatment. What do we do for lipedema? Lipedema involves for us liposuction. So that's a variation on liposuction that we use to remove that diseased fat. Again, it's not just one procedure. It's not just, hey, come have the procedure and you're finished. We believe that the best results come from being taken care of as part of an overall integrated system. That means we have proper patient evaluation, and we want to make sure that that patient doesn't have a significant lymphedema component that's contributing to the leg swelling in addition to the lipedema, because then they need to be treated differently. If you treat a patient with lymphedema with a lipedema protocol, you will have problems. You will have delayed healing. You will have swelling that happens afterwards, but they're fairly straightforward to distinguish if you have the proper team and you have the proper imaging modalities that we perform for our patients. So lipedema patients come with all different types of presentations. Patients that are less advanced can even be taken care of, maybe even both legs at the same time in the surgery center if the swelling is not severe. However, many patients have significant swelling, so we take care of the whole leg all at once in the hospital in a method that's similar to the SAPL surgery. It's not as intense. It doesn't have to be. But we do match that patient specifically to each patient every time to give them the best chance for an excellent outcome. Again, we can effectively reduce small or large volumes, and we preoperatively and intraoperatively, meaning before surgery and during surgery, use the imaging that's required to make sure we don't damage those lymphatic vessels and treat the patient appropriately. The liposuction surgery in our hands, we've gotten it down to performing only one surgery. We now only require typically one surgery for each leg instead of 2, 3, or 4 per leg, because if there's a big leg, we can perform in the hospital, take care of everything at once, and take care of that leg, and then go back and do the other side. Again, we can do large volumes as well as small volumes, depending upon what we need to do. So this is a patient with a small volume lipedema, and we can do that both in one procedure in the surgery center. So 3,400 cc's of total volume, meaning it's about 1,700 or less than a 2-liter soda bottle on each side. And the patient has a good result with significantly improved symptoms and less pain. For a patient that's much bigger, we can't do that in the same way. That patient has a lot more coming out from each side. So here's an example, and this is after surgery 1. We normalize the size of that leg, and this is after surgery 2. So in this case, we had over 17,000 cc's. So that's 8.5 2-liter soda bottles of material that was removed. That can't be done in one time, even in the hospital. The aspirate, again, from lipedema versus lymphedema is different. So the lipedema aspirate is closer to a liposuction cosmetic aspirate than the lymphedema one. So the technique does not have to be as intense, but we are certainly, we use what's appropriate given the patient's condition. Here's a case study also. So this patient's lipedema history has increasing leg pain and swelling over 20 years. This is very typical. We took care of her in only 2 operations. The first one had 5,800 cc's, or almost 3 2-liter soda bottles. The other one, a little bit less, but approaching the same volume. The surgeries were performed in the hospital, so we can allow a safe removal, again, of a greater volume of solids. We're not limited by a 5,000 cc limit like some states and some surgery centers are required, and we can get her done in less surgeries. So again, a lot of volume. This is roughly equivalent to almost 3 2-liter soda bottles. This is how she looked before. And this is how she looked afterwards. So the liposuction surgery can be extremely effective. And again, this significantly reduces the pain in most patients. It significantly reduces the volume in those areas affected. And again, for lipedema, our overall outcome is functional, and we try and make the cosmetic as good as the patient's physiology will allow us to do too. But the overall goal is the functional improvement of especially the pain that's can be very debilitating. And this is how she looked afterwards with significant improvement in symptoms. And then we love getting the photos from our patients, getting back to more normal life and more active life afterwards. Thank you. We'll take questions now. I have one question. Why do some plastic surgeons resect skin after liposuction of lymphedema when it's actually not needed? Has it to do with reimbursement codes from insurance companies? That looks like Dr. Håkan Borson. So hi, Håkan, how are you? I don't know why that's performed, so I can't speak to the other surgeons. Certainly I don't, and I'm no good at insurance at all. I think one of the big impediments in America that we've found is the insurance paying for the lymphedema surgery. So we have a team that that takes extensive amounts of time in helping the patients get their approvals for their surgeries. And I know that's not an option for many patients. So billing codes, how things are billed might impact that, but I'm not so sure. It might be that the post-op compression might not be as good, and so that's one way to achieve compression is to remove some of that excess skin. Could be as well, but that I don't know, but certainly is a possibility. If you have lymphedema and lipedema, can you progress faster because of the lymphedema? The lymphedema, both processes produce significant amounts of inflammation, which are the pain, the swelling, and the pathology that's associated with the leg. So they can feed off each other. And if you have lipedema, which is causing inflammation on its own, the lymphedema will cause that to get even worse. So they will both make each other worse than they otherwise would be. I hope that would be a good answer to that question. Is the aspirate ever sent to pathology for any reason? So we tried to, so I know Dr. Borson in Sweden, and again, I really want to give a shout out to Dr. Borson. He's really been fantastic. He's been a great mentor from before. He really, he and his team, and again, it's a team effort, really have taken wonderful care of the patients and have really been trailblazers in making these procedures a reality. He sent the pathology, I believe he sent the aspirate, meaning the material that we get out of the patients, to pathology to try and find, to do studies to better characterize that material. But we aren't able to do that. Our pathology department, again, we tried, they kind of looked at us and looked at us sideways and said, we really can't help you with this. So we stopped sending it over there. So it gets sent to the trash bin for us. What is the rate? Next question is, what is the ratio of leg to arm surgeries for SAPL? I guess in my office, we see so many more leg patients. I think we tend to see the most difficult, complex patients that are often not able to be treated elsewhere. So we probably have a ratio of, gosh, it's potentially even 8 or 9 to 1 with legs to arms. So most of the patients will be legs. We've also found, so we're doing some data analysis here too. I'm trying to get some papers out now. We found that over 40% of our patients have congenital lymphedema of the legs. So I thought it would be a much lower number, But as time has gone on, I think that the awareness of patients with lymphedema has grown significantly, and patients with leg swelling that they didn't realize were lymphedema are discovering it's lymphedema and are coming to us. For SAPL surgeries, we've looked at our data as well, and I've presented on this also. Patients with congenital lymphedema will benefit equally to patients with secondary lymphedema, secondary meaning secondary to cancer treatment, for example. And so we found the outcomes are identical for both sets of patients, again, assuming that you've taken care of them with the team, with the process, in a very consistent way. Are patients on long-term, another question is, are patients on long-term antibiotics before, during, and after surgery? Can surgery incisions cause cellulitis? So that's an excellent question. One of the biggest issues that patients with lymphedema have is this predisposition towards cellulitis. Their lymphedema fluids are so inflammatory and they cause so much damage that they create this breeding ground for bacteria. They break down the natural barriers in the skin so the bacteria can get in there more easily and set up shop and send an infection and send that patient to the hospital in less than 24 hours in many cases. It can be very dangerous, very debilitating. The patient might be in the hospital for a week with IV antibiotics, or at least a few days if it's caught late. If we can catch them earlier, we can often avoid the hospitalization. So patients with very severe disease, when they come to us, can sometimes be on even long-term prophylactic or daily antibiotics to keep those infections from occurring. We find that after the surgery, once things heal and are going down, the amount of infections and the risk for infections drops off dramatically. And that's because we've treated that inflammation. We are able to get those solids out that are hanging onto those damaging fluids. Those fluids are what drive lymphedema. And if we can get those fluids under control, there's less inflammation, the skin heals, and there's less chance of infection. And so we typically expect to get those patients off antibiotics permanently. Now, can the incisions of the surgery be a source for infection? They can be, theoretically. I guess touch wood, but we have not had a surgical infection from an incision to this point. The surgery is performed in a very sterile environment in very clean fashion. We get that fluid out and we decrease that inflammation. So I think those are certainly things that are in our favor. Infection after surgery is a risk from any surgery, anytime there's a skin incision made for any reason, but those risks are quite low in our hands. For lymphedema surgery, do I mean lymph fluid suction? So I went over, we aspirate the stage 2 solids. So patients that have progressed from a fluid problem to a fluid plus solid problem. We get rid of those solids. Those solids are what are holding that fluid in stage 2 patients, like a wet sponge or a wet Nerf football that's gone in the swimming pool. You know it's over. If you try and squeeze that thing out, you'll never get it out. So we have to get that solid out first, get them back to a stage 1 problem before we could consider microsurgery. Otherwise, the microsurgery is useless, and you'll actually burn bridges, meaning you will try and any surgical site that's used for microsurgery on a stage 2 process is potentially liable to fail and not be usable in the future when we could really use it. And then last question is there going to be a replay for the symposium? So LE&RN will be, so this is our last question, we'll wrap up. LE&RN will be recording this, putting it, as my understanding, is enduring material, and you should be able to access it in the future. Thank you very much.